Welcome to Head and Neck Oncology Journal Club. I'm your host, and today we are covering a landmark European consensus paper that provides the first comprehensive surgical practice guidelines for transoral robotic surgery in head and neck cancers. The paper, published in Oral Oncology in late 2025, was authored by Lechien, Paleri, and colleagues representing three major European scientific societies: the European Head and Neck Society, the European Laryngological Society, and the Young Otolaryngologists Group of YO-IFOS. So, why do we need these guidelines? Well, despite TORS becoming increasingly prevalent over the past 2 decades, there has been substantial heterogeneity across centers regarding when to use it, how to perform it, and how to care for patients afterward. This has made it difficult to compare published outcomes and build a solid evidence base. This consensus aims to fix that. Let me walk you through the methodology first. 22 experts from 11 European countries participated in a modified Delphi process. These were in casual users. The panel averaged nearly 18 years of clinical experience and over 164 TORS procedures each. After 3 voting rounds, 38 out of 41 initial statements achieved consensus, which required 2/3 agreement. Now, let's get to the clinical meat. The guidelines addresses 5 key areas: preoperative assessment, indications, contraindications, surgical outcomes, postoperative care, and the research recommendations. For oropharyngeal cancer, TORS is indicated for clinical T1 to T2 tumors and selected T3 cases. It's particularly appropriate for HPV positive tobacco alcohol negative patients given the potential for treatment de-escalation. Importantly, the consensus validates that the 3 mm surgical margins are adequate for HPV positive disease. This is supported by meta-analysis data showing margin status doesn't significantly impact the survival in this population. For supraglottic laryngeal cancer, TORS is indicated for T1 and T2 tumors involving the epiglottis, aryepiglottic folds, and false vocal cords. Selected T3 cases with pre-epiglottic space invasion can also be considered, provided you can achieve at least a 1 cm margin from the hyoid bone. For hypopharyngeal cancer, the indications are T1, T2 tumors located above the horizontal cricoid plane without invasion of the prevertebral fascia, parapharyngeal region, or cricopharyngeal muscle. Now, let's talk about the contraindications. And this is where these guidelines really shine. Absolute contraindications across all sites include carotid artery invasion, resection requiring more than 50% of the tongue musculature, the need to ligate both lingual arteries, T4 disease, and staging that would require adjuvant chemoradiation targeting the primary tumor site. The panel also lists extensive parapharyngeal space invasion as a contraindication for oropharyngeal tumors, though they acknowledge emerging literature supporting TORS for moderate invasion in T1 to T2 cases. For postoperative care, some key points include: hemorrhage is the primary complication and requires rapid airway protection. Tracheostomy or intubation before attempting to control bleeding has to be done. Importantly, the panel confirms that tracheostomy and feeding tube placement are not mandatory for all TORS cases. This is significant because it highlights one of the TORS main advantages over open approaches, that is, less morbidity. The guidelines recommend 24-hour monitoring in the ICU, recovery room, or a specialized ward. Perioperative IV corticosteroids may reduce the edema and pain, and speech-voice therapy is recommended for swallow and voice rehabilitation, especially after supraglottic procedures. Finally, the consensus emphasizes the standardized outcome reporting. Studies should report conversion rates, surgery duration, margin status, tracheostomy and feeding tube rates, hospital stay, and complications. Swallowing should be evaluated with validated questionnaires and FEES or video fluoroscopy. Voice assessment should follow European consensus guidelines with multi-dimensional evaluation. So, what's the bottom line? This European consensus provides surgeons with evidence based, expert validated guidance for TORS patient selection. The detailed contraindications will be invaluable when facing borderline cases. The validation of 3 millimeter margins for HPV positive disease and the confirmation that TORS can often avoid tracheostomy and prolonged tube feeding reinforces its role as a less morbid alternative to open surgery. You can find the full paper in Oral Oncology. The DOI link is in our website. That's all for today's episode. Thanks for listening to the Head and Neck Oncology Journal Club. Until next time.